Motor control exercise for low back pain, a Cochrane review. It's an inherent desire in practice to attempt to become more efficient and more sophisticated in our evaluation and management of patients. Basic science evidence is a guide, but basic science is often discovered in too controlled and separate an environment from actual real-life patients to allow application to management approaches. We believe, or at least hope, that research will identify either potential sources of risk or cause that we can then, for both evaluation and management approaches, isolate to that cause. Yet this reductionist approach seems to imply that we can do better with more focus, and that this focus is inherently more sophisticated and superior to a more broad approach. Illustrative of this past mindset was our hope that by specifically identifying the underlying structural cause of back pain, we could use testing and treatment specific to that cause. It's become disappointingly obvious that this isolationist approach is ironically too simplified, and that it is often difficult, if not impossible, to identify a specific isolated source. External factors such as patients' behavioral profiles and lifestyle patterns complicate matters even more. The results of the publication we will review may again point to an over-reliance on the principle of specificity that perhaps is either not true or unnecessary. The results of this mindset of specificity may be a protocol that, although organized and logical, may be no more than sophisticated ritualism. The particular concept related to this review is that low back pain and spinal pain in general may be due to dysfunction of deep spinal musculature and related supportive musculature, and that by isolating structures utilizing the most electromyographically stimulating exercises, we will as a consequence be more effective than through the use of more general approaches to exercise. The title of the publication is Motor Control Exercise for Nonspecific Low Back Pain, a Cochrane Review, published in Spine in 2016. So what are motor control exercises? They're exercises that focus on and isolate the deep spine muscles for control and stability, while maintaining normal respiration, progressing to more complex and functional movements integrating deep spine muscles with global trunk muscles. This publication represents a co-publication of two Cochrane reviews evaluating the effectiveness of motor control exercise for patients with acute, subacute, and chronic nonspecific low back pain with or without leg pain. The researchers only included randomized controlled trials and those that compared motor control exercise with placebo, no treatment, another active treatment, or when motor control exercise was added as a supplement to other interventions. They did not include generalized stability exercises or Pilates exercise. However, there is a separate Cochrane review published in Spine in 2016 that does specifically address Pilates. It's entitled Pilates for Low Back Pain, complete republication of a Cochrane review. They conclude, quote, there is low to moderate quality evidence that Pilates is more effective than minimal intervention, with most of the effect sizes being considered medium. However, there is no conclusive evidence that Pilates is superior to other forms of exercise, unquote. In the current combined Cochrane review for motor control exercise, there were 181 full-text articles assessed and a total of 32 trials included. For chronic low back pain patients, 16 trials compared motor control exercise with other types of exercise, including general or conventional exercises, stretching, strengthening exercises, graded activity, and McKenzie exercise. A further breakdown of trials is that 7 trials compared motor control exercise with minimal intervention, which included a placebo physiotherapy intervention, education or advice, and no treatment. 5 trials compared motor control exercise with manual therapy. 3 trials compared motor control exercise with a combination of exercise and electrophysical agents. 1 trial compared motor control exercise with telerehabilitation, which was based on home exercises with phone calls twice a week. Primary outcomes included a visual analog scale, numerical rating scale, and disability evaluation. The secondary outcomes utilized were function, quality of life, global impression of recovery, return to work, adverse events, and recurrence. Not all systematic reviews can be extended to a meta-analysis, but much of the data in this review allowed for this grouping. For continuous data, effect sizes were calculated as mean differences, and for dichotomous data, risk ratios. One mistake made interpreting studies is not to gauge the size of treatment effect. For this review, small effect sizes were indicated by a mean difference of less than 10%, medium effect sizes a mean difference of 10 to 20%, and a large effect size with a mean difference greater than 20%. A clinically important effect was considered when the magnitude of the effect size was at least medium. Now the results. For chronic low back pain and pain intensity, there was low-quality evidence that there is a small effect, but not clinically important effect for motor control exercise reducing pain intensity at short-term follow-up. And there is high-quality evidence that there is no clinically important effect for pain at intermediate and long-term follow-up. One advantage of systematic reviews and meta-analysis is that they often pictorially demonstrate all the findings of all studies in one graphic called a forest plot. Forest plots allow the forest view, showing not only results, but also the range of results, a visual comparison to other studies, whether overall that effect is consistent, and finally the size of that effect. Here's an example. The triangles represent the mean for the results of that study, the line the confidence interval, and notice that the vertical line demonstrates whether there is an effect or not by being on the left or right side of the zero indicator respectively. This can also be used to show comparison effects between two approaches. This particular example shows a mix of results with some above and some below the zero marker. Even the same study may show a range above and below the zero line indicating the confidence interval. This would lead one to be careful in drawing any conclusions based on a single study's results. Here's a summary of the forest plot for motor control exercise versus other exercises' effect on pain. We can see that for a long-term effect greater than 12 months, there is a minimal difference in favor of motor control exercise, but not considered clinically significant. For an intermediate effect, 6 to 12 months, the mean is still close to the zero line. Only for the short-term effect, less than 3 months, do we see a possible advantage for motor control exercise. Do know, though, that most studies' confidence intervals cross the midline into the favoring other exercise territory. Here's the forest plot for motor control exercise versus minimal interventions effect on pain. Here we see that for all time measurements, short, intermediate, and long-term, there is an advantage for using motor control exercise. For chronic low back pain and improvement of disability, there was low-quality evidence that there is a small but not clinically important effect at short-term, and a high-quality evidence for no clinically important effect at intermediate and long-term follow-up. For the secondary outcomes, there is moderate quality evidence that there is a small but not clinically important effect of motor control exercise for improving function at short term, and no clinically important effect for intermediate and long-term follow-up. And here's the forest plot for motor control exercise versus minimal interventions effect on disability. Again, we see the advantage of motor control exercise over minimal intervention for all 3 time point measurements, indicating that doing something is better than doing nothing. Patients were also evaluated for their perception of their global impression of recovery. There is moderate quality evidence that there is no clinically important effect at intermediate and long-term follow-ups. So why would there be no difference? Our management is often based on what appears to be a logical extension of some known basic science element. For example, the multifidi seem to diminish in size or activity in patients with low back pain, so therefore strengthening them with a focus should resolve the problem. Well, perhaps this is the chicken or egg phenomenon. Multifidi size and activity may be a result and not a cause, or more likely, general exercise is sufficient to stimulate the multifidi even though they're not focused on. And another possibility, anatomically or structurally, there may be a relationship. However, this may not translate to a difference in patients' perception of pain or function. Another element not discussed in this article is the level of compliance. Given the included randomized controlled trials followed patients for a 1-year period, how much does compliance play a role in these results? It appears that many studies prescribed exercises for the short term, so adherence past that point would be important to know and compare. So in summary, this systematic review indicates the following. There is some evidence for motor control exercise to be better than minimal intervention, even measured a year later. However, this effect is not as dramatic as would be expected. We also can see that compared to a long list of other exercise options, including general strengthening exercises, there does not seem to be a convincing argument for motor control exercise other than patient or doctor preference. The practical questions that then arise are, will the increased investment in time by the doctor to prescribe and monitor motor control exercise be compensated if evidence indicates no clear advantage? Will patients be willing to focus on the subtleties and dedication to the specific motor control exercise approach versus standard exercise if they hear that general exercise is just as good? So certainly larger studies are needed with a focus on monitoring compliance.